Nice, nice. So Andrew, I know we talked a little bit before, but still, can you like introduce yourself a little bit for the audience?
Yeah. So my name is Andrew. I am a sports and orthopedic physical therapist. I'm originally from Baxter, Iowa, so a really small town in the Midwest. It was a really great place to grow up. And then from there, I did my undergraduate degree at the University of Iowa, and I went on to complete my physical therapy degree at the University of Iowa. After that, I went to Madison, Wisconsin, where I completed a sports residency at UW Health. And then since 2021, I've been here based in the Vail Valley area in Colorado. I'm working at Howard Head Sports Medicine. So it's been for about 4 years. And then during the winters, I'm a part of the medical pool for the U.S. snowboard team. And so I work with the U.S. border cross team internationally.
Nice, nice. So, um, when you let's say when you work with USA ski and snowboard, like what are like the main injury you guys deal with?
So I suppose it kind of depends. So there's a lot of, border cross is a very fast-paced racing environment. So a lot of it is high impact related injuries. So these are, upper extremity fractures from falling and that blunt trauma. Sometimes it's, they're falling backwards, so blunt trauma to like the spine or concussion. But of course, with, all ski and snowboard related activities, there's lots of twisting and turning. So the event for like an ACL injury or another complex lower extremity injury is pretty common.
Nice, nice. So, um, I want to like talk about like ACL tendon, like sorry, ACL tear. So, before we talk about the rehab part, so I know there's like hamstring graft and patellar tendon graft. So can you kind of talk to me about like these different operation for ACL tear?
Yeah. So I suppose we see a variety. There's, really three or four options. Out here, we work with the Stedman physician group. So they're a really well-known physician and orthopedic surgeon group. And I would say by and large, probably like 80% of the ACL reconstructions, the graft of choice is a bone patellar tendon bone graft. So there's pros and cons of each graft. I would say the most prevalent is a bone patellar tendon bone. And then emerging over the last couple of years is the quad tendon graft. And then I would say less frequently nowadays is a hamstring graft, and kind of depending on the age of the athlete, a cadaver graft. I would say most of the like local or ski and snowboard injuries, if it's has a ACL reconstruction, they're going to opt for the bone patellar tendon bone graft.
Nice. So, um, for different procedure, is there like is that gonna affect like the rehab or return to play protocol?
Down like long term, I suppose those differences are there, but maybe relatively smaller and more nuanced. But from an early operative, post-operative standpoint, for sure. For example, like a hamstring autograft, there's no graft site from the knee extensor mechanism. And so usually these individuals can restore their leg extension or their quadriceps strength more quickly. There's less discomfort associated with the leg kick or leg extension exercise, and so it's a little bit easier to progress and overload. The con of a hamstring graft is that they take the hamstrings, and so the hamstrings provide some, rotation stability to the knee joint. It backs up the ACL from a anterior shear or anterior tibial translation standpoint, and so especially at the deeper ranges of knee flexion, around 90 to 70 degrees, those deficits from a strength standpoint tend to persist for a long time. And not only strength, but rate of force development from a hamstring perspective. So pros and cons. Bone patellar tendon bone. You tend to progress relatively quickly through the first couple months, as long as pain is well managed. And with all of these surgeries, getting and obtaining a quiet knee, so minimal joint effusion, making sure you can get the knee fully straight, starting to work on some progressive knee bending and quad activation are really important. Um, I think now that we're starting to see more and more quad tendon grafts, I would say those can be a little bit more tricky in the early post-operative phase. It's I would say at a year, from what I see and from my experience, the performance metrics tend to be about the same. But for the first couple of months, a quad tendon graft can be really painful and progress a little bit more slowly. It's really hard to get the knee to bend, especially with the hip extended, even though it's a really important piece to try and regain or and restore. And then certainly from like a knee extensor torque or a force output standpoint, a little bit more slowly for the first like 3 to 6, 7 months.
Cool. Cool. So, uh, I talked to a few PT and they say like when it comes to ACL return to play or ACL rehab, uh, do they tear their meniscus? It's gonna affect like the rehab protocol. So why is that?
So I suppose it depends on the area that you're in and likely the physician group that you're working with. Out here with a ski and a snowboard population, having a concomitant meniscus injury with an ACL is pretty common. I would say, like in general, it happens about 40% of the time, and you'll have both injuries. So you'll likely have a meniscus repair, or depending on the type of injury to the meniscus, maybe a partial meniscectomy, as well as an ACL reconstruction. And if you have a repair to the meniscus, it's a shock absorber within the knee joint. And so we want to make sure that we can restore and get as much good quality tissue healing to that as possible. So oftentimes, from my experience, what we see is really for the first 3 up to 6 weeks, the bending range, or the knee flexion range of motion is going to be limited to about 90 degrees. And the rationale is just like the deeper ranges of knee bending tend to load the posterior portion of the meniscus a little bit more. And so we just want to try and provide a really good healing environment to that meniscus so that we don't have any issues when we return to loading. And it's funny, you would think that an additional injury can make things worse and harder to progress, etc. And I would say it's really a mixed bag from my experience. I think the pro of a meniscus repair is that there's not a lot of weight bearing activities that you can do. And so for the first 3 to up to 6 weeks, the individual has to work on really drilling, like getting the joint effusion down, really making sure we can get the knee fully straight, we can get the quadriceps starting to work. And it allows you to obtain a really quiet knee and progress, quadricep activation a little, maybe with more of a priority, compared to if you were also balancing like, regaining more knee bending control, weight bearing progressions, etc. So yes, I do see like more maybe arthrogenic muscle inhibition for like a set period of time, but I think it allows a really good opportunity to get a good quiet knee and really focus on good quadriceps control.
So, I hear some like back in Taiwan I work with some physical therapists and what what we trying to accomplish is as fast as they finish the surgery, we want them to like start walking and whatever, as long as it's not painful. Does that mean that with meniscus tear, we're gonna postpone that?
Yeah, well, I would say it depends on the type of meniscus repair. If they're able to start weight bearing, occasionally what we'll see based on the type of tear is you can weight bear or you can put as much weight as you want through it, as long as the knee is locked fully straight. So that's sometimes an option depending on the type of meniscus repair. And you're exactly right. So like we want to make sure we have a good quiet knee joint. The knee feels good and we can start to progress the quad. But we also know these prolonged periods of immobilization or non-weight bearing, especially from a cartilage like homeostasis or a cartilage health standpoint, are not good. We want to make sure that we can restore the load to the knee joint. So it's definitely a trade-off. We want to make sure if they have the ability or the capacity to start weight bearing, that we start to progressively load and make sure that the knee joint can tolerate it. So it's not painful, it's not increasing in swelling. So there's pros and cons and kind of caveats to that. We need to get the load back to the knee joint, but we also got to make sure that we're not increasing this joint effusion as we do that.
Cool. So, kind of want you to walk me through that. Your ACL rehab protocol start from probably after they done their surgery. What would you do like after until like the day they go back to f perform?
Okay, that's a loaded question. There's a lot of stuff that occurs.
Yeah.
Well, we'll start in the early phases. My mind, I'm a systematic thinker. I like frameworks, and so breaking it up into chunks. So we know that if you look at kinematics and kinetics at the end stage or return to performance and practice, performance there is quadriceps performance there is correlated or has a relationship to early quadriceps performance. So then if we kind of transition, we know that like, okay, this early phase of rehab is really important. And we know that usually the early phase of rehab from a time-based standpoint is usually somewhere between like 12 and 16 weeks, more or less, depending on how they're doing. But so I say at the 12-week mark, we know that we ideally would have somewhere around 70% limb symmetry from a quadricep standpoint, and they can produce, somewhere between like 1.6 and 2.0 Newton meters per kilogram for torque. So if we know that's our benchmark from like a quad standpoint, we can try and start to work our way back to, really in the first 2 weeks and say, hey, can we start to get it activated? Can we start to hold any weight? Can we hold our own body weight from a leg extension standpoint? And then from an open chain manner, you can progressively dose up to those values that we're looking for from a 12-week standpoint. But from like a criterion based standpoint, usually around the like 2 to 4 week mark, we're starting to work on the valved force decks, and we're looking at quiet stance from an even weight bearing standpoint. We start to work at single leg or start to look at single leg stance in terms of total excursion and usually like medial to lateral velocity. So how much postural sway do you have side to side? And so once the quiet stance and the single leg stance are starting to flirt within 10%, then we're starting to look at, what does our double leg movement strategy look like? So how much do we offload the surgical limb from a double leg squat standpoint? We want to try and get within 10% ideally, and then we'll start to look at a kind of a combo between a single leg squat. And here we're less looking at, potentially impulse from an eccentric or a concentric phase, but we're really starting to work on the depth or the negative displacement with a single leg squat, trying to get that within 10%. And then from a functional standpoint, going up and down stairs. Going upstairs tends to be a little easier. Going downstairs tends to be a little tougher. And so a test that we'll start to look at is a step down test where we get about a 12-inch box. We try and standardize that as best we can, and we'll have the individual quietly roll off and step down off of the box onto the force plates. And we'll be looking at peak landing force for each leg. We typically see that as you descend on your surgical leg, the peak landing force on your other, like when you land onto the box, is a little bit higher. And so that's a way that we're trying to get an insight to force production and lowering down mechanics. And I would say a lot of those ideas and how we've started to frame our return to sport testing has a lot to do with Aspetar and Rula Katsafaki's work. Yeah, so definitely want to give credit to them pioneering a lot of these test and measures that we started to adopt. So that would be like the first, roughly 6 to 7 or 8 weeks.
And so what about after the early phases? What's after that?
After the early phases, we're starting to look at quadriceps and hamstring strength. So we'll do an isolated isometric test at the 12-week mark. And then after that, pending performance, we will start to do a counter movement jump and then a single leg counter movement jump on the force decks. And so the counter movement jump, we're starting to look at more of an offloading strategy. Can we be symmetrical with our down and our up? And then from a single leg jump perspective, we're starting to look at the performance. So can we get equal or within 10% from a height perspective? Since we know now with a lot of the work coming out that a single leg vertical jump likely gives better insight to overall knee work and joint power versus a triple hop or a horizontal hop from an objective standpoint that we can capture. So from there, I would say from like a general public standpoint, if we can successfully mastered those like jumping the counter movement jump and the single leg jump, most of the time you're in a really, really good spot as long as your strength, is above 90, 3.0 Newton meters per kilogram from a quad standpoint. And then for any college or professional athletes, now we're starting to work down into the drop jumps. So we'll assess a double leg drop jump and then a single leg drop jump. And we really only have a number of clinicians that assess this because the one is a hard test from an athlete standpoint. So if you haven't done a drop jump or performed and practiced a double leg or single leg drop jump, it's a pretty tough task. And so we want to make sure that these individuals have done enough plyometric training, especially high intensity plyometric training, before we're really even starting to test these metrics. So yeah, so I would say kind of the end stage for us from an objective standpoint, especially on the force plates, is a double and single leg vertical drop jump.
Nice, nice. So I'm glad that you mentioned you train plyo before you test. So how early would you implement like plyo or even like just maybe fast strength training whatsoever into like your like rehab protocol?
Yeah. Good question, because we know that it's one thing to have, strength restored, but the ability to activate that muscle rapidly and produce, a higher level of rate of force or rate of torque development is a whole nother story. And so really, as soon as they can tolerate that in the early, like even a couple of weeks after surgery. So for an example, you can take a quad set, a simple exercise that most rehab specialists will do, and you can try and have them activate the muscle as fast as they possibly can. Or reciprocally, you can go, maybe left versus right and just start to turn the muscle on and off as fast as you possibly can. Because there's the debate about like what contributes most to like the neural determinant of rate of force development. Is it the intent to maximally, explode, or is it the true velocity of which is achieved after you maximally explode? And so different theories, but at least in an early phase of rehab, you can certainly optimize or at least target the intent to drive fast with a lot of your exercises. Another, example would be like you're on a bike working on some range of motion. And then maybe every 10 revolutions with your surgical side, I want you to slam down as fast as you possibly can. So it's an easy way with low amounts of load to introduce, relatively higher amounts of velocity and really try and target these neural underpinnings of rate of force development. From a plyometric standpoint, though, it's a good question. I think this is something that, like, as I've gained more volume and experience with treating these complex lower extremity injuries, I think what I used to do and what I no longer do is I used to wait until we have 70% limb symmetry, somewhere pretty close to 2 to 2.0 Newton meters per kilogram from a torque perspective, and then we start to do more plyometric work. And I think what I found was and I started to appreciate is the ability to, um, you know, improve fast stretch shortening cycle capacity takes a really long time. One, you have to build up a lot of volume from a low intensity perspective in order to start, microdosing these higher intensity bouts of work. And it takes many months in order to do that. And so the earlier that you can start to introduce this in a way that's really well tolerated for the joint, really is the better. So for example, stuff in the first, maybe month or two from like a prep for plyometrics that I have found productive is even like a stair stepper. And the idea is like when you're going up the stair stepper, you bring your foot up and then you start to kind of whip it down. So I usually say like bring up to whip down as a cue. And so you can just get in this pattern of like pre-activation to help prep for plyometrics down the road. Usually, once those are tolerated well, and once we can get to around 50% limb symmetry from a quadricep standpoint, and ideally you'd be doing some form of like an ankle iso push from a calf standpoint. But once we're at about 50% symmetry, then in like an anti-gravity or maybe like a gravity minimized position, start to do double leg pogos and just see if you can get that stimulus. Examples would be like band assisted pogos, within a squat rack. Like you've got a band that you're pulling down to unweight your body. And then all of a sudden you can start to, really work on this pre-activation, to prep for, full weighted plyometrics. We use a lot of the reformer or like a shuttle machine. It's a great way to try and isolate the quadricep because you're on your back and just from a constraint standpoint. But it's a good way to unload the body. Like you can put 20 or 30 pounds on and just start to work on, that motor control patterning from a plyometric standpoint.
Cool.
Then progressing towards 70%. Once we can hit 70% symmetry, then we start to progress the body weight, the gravity, full gravity type exercises.
Cool. I know the answer you're probably gonna say it depends, but like can you give me a roughly like time frame? I know people hate the time frame thing right now, but can you give me roughly a time frame that when would you start implement like the band assisted pogo like you mentioned into like the return to play?
Yeah, no, that's a good question. Yeah, trying to go based more on a criteria. So I would say when they hit 50% symmetry, which can be somewhere around like the 8 week mark, I would say 7 or 8 weeks from my experience, and an athlete that's, young, healthy, progressing pretty well. And then I think a key piece to this is they have like a strong plyometric training background or experience with training. If it's someone who, has not performed a lot of plyometric work in the past, it's probably going to take a little bit longer because now you're introducing, too many new stimuli, and that can be tough. And so I would say from a time frame, usually it's around that 50% mark is when I like to do the band assisted, and that 50% LSI mark tends to come around, maybe the 8 to 9 or 10 weeks post-op, kind of more or less, but that would be a good situation.
Cool, cool. So another question about like the return to play protocol is, so last year, me and my boss we went on a trip to like 11 D1 Power Four college
Yep.
basketball team to test their decelerate quality. We used 1080 and force plate. So on force plate we test their counter movement jump, single leg counter movement jump, and drop jump, single leg drop jump. So most of the athletes are really pretty good at counter movement jump, right? Everybody tests it nowadays. But when it comes to like drop jump, like single leg drop jump, even drop jump, some athletes don't know how to perform drop jumps. So uh when it comes to like implementing these tests into like the return to play protocol, is it gonna be harder since it's already a return to play like thing and implement these like probably a little bit harder test for like even normal athlete. So I guess what I'm asking is like from your experience, what is like to like implement these tests to the athlete?
Yeah, I agree. Yeah, it's tough. Um, from a reliability standpoint, right? Every clinician needs to be administering it and executing it, exactly the same. Otherwise, it's really hard to compare results from athlete to athlete, even within kind of the same sporting context. So I would say like barriers is certainly like for example, Howard Head has 80 to 90 clinicians, and implementing these types of tests on the force plates to in a reliable way to get really good data that we can utilize to make and drive decision making takes a long time. And we're not quite there yet from a drop jump standpoint. There's a handful of clinicians that when it's time to perform these drop jumps will take that task to make sure that it's done reliably. I would say something else that we're starting to experiment or that I have found to work pretty well in a clinical standpoint across like a variety of different sports is a form of like a counter movement rebound jump test or a 10-5 rebound jump test. Um, it's easier to kind of translate from some of the pogo work that a lot of people have been doing or maybe repeat hurdle work that people have been doing. And in addition, like if you do a maximal jump and then try and rebound jump, the height is only as high as you can go. And so I think from an athlete standpoint, that makes a little bit more intuitive sense, and it takes away some of the fear or maybe confidence issues associated with like, all right, hey, we have a 15 or a 30 centimeter box. I want you to jump off of that. So I think an area to explore further and something that we're starting to look more and more into for a way to get an RSI value associated with these drop jump tasks is like a 10-5 rebound jump test.
Cool. And another question is like, since you work with like these athletes that like their event are probably like really high intensity, their like landing height are probably pretty high. Does that also gonna like affect or like change your return to play protocol?
So, yes and no. Like at the end of the day, there's still like, these drop jump, for example, it is a proxy of a neuromuscular like physical quality that we're trying to assess. And so like you can only get as close to that using proxies as possible versus, just going into the sport. So ideally, like from a, especially from a ski and a snowboard standpoint, there's really not a lot of training that's going to prep you for the mountain. And so after you've hit the KPIs that are of interest, whether it's a double or a single leg drop jump or whatever, once you've hit the organization's KPIs, and now it's time to develop some capacity of like on snow training. So usually trying to work up to around 50% of preseason volume is what is recommended with US ski and snowboard. And they do an awesome job progressing that, like a very detailed multi-step return to play protocol. Um, and I think it's interesting because, sprinting is obviously like a big piece of most sports. But when I have ski and snowboarders, they don't do a lot of full-on sprinting. That's not something that they have to do in order to be successful within their discipline. And so I think, 3 or 4 years ago, I would have been doing a lot of, plyometric and progressing into some running. And there was a couple of times where I ran into like some joint effusion issues when I pushed the running progressions. And then eventually I kind of just took a step back and I reflected and I'm like, why am I pushing these running progressions when they're not going to have to run to be successful with their sport? They do need to handle like high impact, high intensity plyometric work because there's certainly repeated landing and high impact loads. Um, so maybe that's where we spend most of our time. Like it's probably more beneficial to really ramp up the plyometric continuum. Versus try and get in these like repeated sprint bouts. So especially from a ski and a snowboard standpoint, it definitely creates like a unique situation. You had mentioned 1080, so we don't have access to 1080, but that would be something like from a deceleration standpoint, we do train, like we just don't have the ability to directly test the deceleration capacity with 1080. But certainly like you're on a mountain with a massive slope with a lot of gravity pulling a fast athlete down. Really, and a lot of these injuries occur when you don't have the capacity or the neuromuscular ability to decelerate your body. And so we do a lot of those, training progressions, but we just don't have a great way right now of truly testing the deceleration capacity that you could do with like 1080 sprint.
Cool, cool. So I was talking to another coach and he said like the the main reason there's a lot of ACO happen in team sport is because a lot of time they don't know how to like decelerate properly. Would you say that's kind of the same thing that happens in like ski or snowboard?
I would say it does account for a large amount of injuries. There's a ton of factors, like snow that's maybe too sticky and grabs your ski or your snowboard, or maybe snow that's too icy and you can't get a good grip. So weather elements can play a huge role with skiing and snowboarding. So time of day, quality of snow, um, temperature for sure. So I would say deceleration is a huge piece by and large, but it's certainly hard to say if it accounts for all injuries. There's a ton of factors that go into that.
Cool, cool. So, I saw a lot recently I saw a lot of like people share about like early phases of return play from ACL, right? So why are people talking about early phases of return play or early phase of rehab from ACL?
Well, I'm glad that you're seeing that. That's good. I think if we as rehab professionals can really optimize the early phase of rehab. That sets the athlete up to have a lot more time working on the higher order physical qualities with the strength and conditioning team, the athletic development team, the athletic training and strength and conditioning staff. So the earlier we as rehab professionals can really dial in and optimize that early phase of rehab. I'm not necessarily an advocate for like returning much earlier from an ACL injury, but if we can knock out the basics faster and get really good at them, then it allows and like frees up a lot more time to develop these qualities such as like fast stretch shortening cycle capacity that take a long time to develop. And so hopefully that's one of the reasons where, this early phases of rehab is starting to gain a little bit more popularity.
Cool. Does that mean like, because I know nowadays there's like accelerated Achilles tendon protocol or accelerated ACL rehab protocol. Does that mean like you're trying to like help athlete get back? Like, I know you kind of answered that, but is the whole protocol or like the whole emphasis on early phases means like trying to get athlete faster, trying to get them back to perform or back to play faster?
Well, yeah, I guess a little bit bouncing off of my last comment where I don't know like if a true like, accelerated meniscus return to play protocol, if we're truly going based off of a criterion-based approach, you can only progress as fast as the individual in front of you is going to progress. Whether the physician team or the surgical group gives you like the clearance to do things earlier, if they can't tolerate it from a knee joint perspective, such as joint effusion and pain, then or not having sufficient knee extension and flexion range of motion, then a lot of the other stuff's not going to progress, and you won't be able to accelerate. So, still, I think as technology emerges and there's a lot of crazy cool and fancy ways to do things, I'm just a big proponent of dialing in the basics, setting expectations, and making sure that like our role within the performance model is usually the early phases as a physical therapist. And so if we can do everything we can to just really dial in and make sure that that is really good, then the whole performance team is going to benefit, and ultimately the athlete, the number one priority, is going to benefit.
Cool, cool. And uh I know testing nowadays everybody use force plate, but do you guys still use like three hop tests, like posterior or like wait, yeah, posterior three hop test and anterior three hop test?
No, and most of this is based off of the more recent work from Rula Katsafaki and Aspetar. But yeah, we've started, we want to try and make our testing process as, relatively simple, clear, and concise as possible. And if the triple hop wasn't adding a lot of value to like our decision making, then ultimately we as an organization decided to remove it. I think it's valuable. Like we need to be training that certainly. But if the goal is to try and get an estimate to like, knee joint deceleration capacity, we're really not gaining a lot of that from a triple hop test. Where we can start to gain some insight to, knee joint deceleration with a single leg vertical jump. So just from like a conciseness, and then making like these 40-minute to an hour testing windows that we often have as easy as possible for the clinician, as simple as possible for the athlete, without extras. We started to remove that.
That's awesome. That's awesome. So, would you think like I know we talk I know we kind of talk about this, but what would you feel like uh in the future, what will ACL return to play be like? Are people gonna try to make it faster? I guess you kind of already answered that, but
Making like get
like
going back to sport quicker.
yeah,
We're going
yeah.
to be able to do
I
that.
mean in the future. Yeah.
I think, yeah, I think in time, I think right now is a really wild time in the rehab and performance space with all of the new technology emerging. Even 5 years ago, you would be hard pressed to find a lot of rehab centers having force plates, or handheld dynamometers that can assess rate of force development, like the Dynamo Max. from Vald. So you don't have to have these, like an isokinetic dynamometer to be really dialed in with some of your objective measurements. So that's came a long ways in the last 5 years. And I think in another 5 years, as more and more clinicians on the rehab side of things are able to get familiar and competent and comfortable with these devices, then I think what that's going to do is it's gonna better dial in our exercise dosing and our prescription. That ultimately will probably condense that time frame of return to sport because they're able to meet those milestones a little quicker, just because we have better objective progressions. But it's not going to change biology and the ability of the graft to heal and those considerations. But yeah, I think in time things will start to move up, but mostly from a performance and like meeting those objective criteria sooner because we know how we're progressing over time a little bit better.
Yeah, because I remember talking to like coaches and therapists. They say like you can get athlete back to like play basketball probably like after 6 months. But if you want them to be like, fully like perform like the way they were, it's probably gonna take a year or like year and a half. So
And I
why do you,
would
yeah.
there's there's just so we can do all of the neurocognitive training possible, whether you use blaze pods or dual task or visual cognitive, and those are great constraints to like the neural system. But there's not a lot of things that just truly replace like playing your sport. And so even if like for example an individual would meet all of the objective like physical capacity testing at like 5 or 6 months, I'm still a huge fan of not like rushing the entry point of competition sooner, but spending the next 5 or 6 months slowly reintegrating different types of sporting context with practice and gradually reintegrating back into practice and team sporting events.
Nice, nice, nice. I guess that's all the question I have for you today. So, for those who are interested in what we're talking about today and they want to learn more about ACL return to play, especially early phases of ACL rehab, where can they find you?
Yeah. I my email is a broderickpt@gmail.com. I'm always happy to have discussions and collaborate. And I'm trying to get more active on LinkedIn. I think it's a really neat way to be able to learn from others and connect with others in the rehab and performance space. So if you're on LinkedIn, I'm trying to get better at it, and I'd be happy to connect with you.
Nice.